Hey everyone, welcome back to my podcast, Anatomy and Physiology Bit by Bit. I'm your host, Dr. Steve Sullivan, coming to you from Bucks County, Pennsylvania, just outside of Philadelphia, where I've been teaching A&P since 2002. Today we're going to continue our discussion of nutrition. We'll talk about serum, lipids, proteins, vitamins, and minerals. It's important stuff. But you really do not want to miss what I have for you first. Recently, I spoke with Dr. David Kaufman, who for many years was the sideline neurologist for Michigan State University's football team. If you're not familiar with college football in the U.S., Michigan State is a Division I Big Ten powerhouse with a rich history. We're talking elite athletes in a collision sport, and Dr. Kaufman was the neurologist responsible for their health and well-being, and he wrote a book about his experience called We Need You in the Locker Room, a neurologist's journey behind the scenes of major college football. Dr. Kaufman is also a professor of neurology and ophthalmology at Michigan State University, and we talked about what it's like to treat high-level athletes on the field of play, concussions, his research, and more. I put a link to Dr. Kaufman's website in the show notes so you can learn about his experience and maybe even get a copy of his book. So without further ado, please enjoy my conversation with Dr. David Kaufman. Okay, I'd like to welcome Dr. David Kaufman to the show. Dr. Kaufman is a professor of neurology at Michigan State University and is the founding chair of their Department of Neurology and Ophthalmology. But what Dr. Kaufman is here to talk about is his time as a sideline neurologist for Michigan State University football. That's the green team in Michigan, not the other one. He's also the author of the book, We Need You in the Locker Room, which is all about his experience with Michigan State football. So Dr. Kaufman, welcome to the show. I know I kind of let the cat out of the bag a little bit with that intro, but would you mind telling our listeners a little bit about yourself, your background, and the book you wrote?
Well, Steve, thank you for inviting me here to speak with you and your listeners. It's a terrific opportunity. So I am a tenured professor of neurology at Michigan State University and serve as MSU's Assistant Vice President of Clinical Affairs. I've been interested in a variety of different neurologic issues over the years. My original NIH work was devoted to optic neuritis, multiple sclerosis, other funding related to cancer effects in the eye, and then stroke, but have been at this university for 4 decades.
Wow, that's a long time. And Michigan State is in East Lansing, Michigan, is that right?
Yes, absolutely.
Yep.
Michigan State is in East Lansing, Michigan, and despite what people think, I did not arrive here when it opened in 1855, but I have invested my professional life at this university. Terrific place, Steve.
That's great. I do know we have a little bit of a Philadelphia connection. You are from Philadelphia originally?
Absolutely. Very proud Eagle fan. I don't tell that to many Detroit Lion fans, but love Philadelphia, love the food. Sisters are still there. Wonderful, wonderful place.
That's great. Yep. I live in Bucks County, which is just outside of Philadelphia. So it's one thing to be a neurologist, to teach at the university, but how did you end up on the sidelines of a Big Ten football powerhouse like Michigan State, treating players on the field? And how long did you do that for?
Well, it's a very interesting story. I used to sit in section 108, row 23 in the super upper deck of Spartan Stadium. It is as far away from the field as you could get, 400 or 500 yards away. What happened in 2010 is people began to realize that concussion was a major issue in football. And so Michigan State University made a decision that as a team physician, it had wonderful orthopedic surgeons, had a phenomenal individual that there was their lead team physician in Randy Pearson, but they felt that they needed a neurologist based on the emerging concussion crisis that was noticed within collision sports. And so I was approached by the lead team athletic trainer, Jeff Monroe, and explained that he would like to change where I sat on Saturdays. And so being naive, I said, well, it couldn't be a worse seat than in the upper deck in section 108. Where do you want me? What are you talking about? And he said, well, we need you in the locker room and we need you on the field. Would you be willing to do that? And I was thinking to myself, this would be like a dream come true. Here I am deep into my adult life and thinking to myself, I wonder what actually happens on the field. I mean, what goes on, what happens in the locker room, what's it like to travel? But I knew I would never have that opportunity. And here was the lead athletic trainer providing me with a path to do that. And so it was simply the concussion crisis of 2010 and Michigan State's interest in shielding its players that they wanted a neurologist available to the team physicians in real time.
Well, it's serendipitous, right? I mean, you were just there and they needed you. It's a big deal when you get into big time football like that. So I look at these elite athletes at a program like Michigan State, and it must have been pretty intense on the sideline and in the locker room, the speed of the game, the size and strength of the players. Can you reflect a bit on what the experience was like being responsible for the health and well-being of these student athletes?
When you're sitting in the upper deck sipping a Coca-Cola, you have no clue of the speed and size of these student athletes. It is a remarkable thing. What I found was off the field, they are by and large, almost all of them, wonderful, wonderful people, far better than you might realize. Very polite, very giving, very invested in their sport and also the university culture. But the reality is that when they step on the field, they're very different. They are highly disciplined individuals that understand violence, that are playing a collision sport, virtually to a man, wonderful human beings. But when they step on the field, they're quite different. And that's the way the game is played, and that's the way it's taught. So I think being among them was remarkable, a remarkable experience in a variety of different ways. How do they prepare for important games? How do they prepare themselves to absorb punishment and also to deliver blows? How do they prepare themselves for victory? How do they accept loss? Watching that part of the game was equally interesting. I would say straight out of the gun, one of the things that Jeff Monroe, who was my mentor in trying to change me from an academic neurologist into a sports neurologist, he had various things that tried to clue me in that it's a bit dangerous on the sidelines. It's really dangerous on the field, but it's a bit dangerous on the sidelines. His statement to me was, watch the players and not the ball. I said, what do you mean? He said, a football will not send you to the hospital, but if you watch the football and you don't notice the 250-pound fullback running for the football that ends up hitting you, that's how you're going to end up in the hospital. So always remember to watch the player and not the ball. So my first live game, of course, I had forgotten everything I had been taught, and a gentleman by the name of Le'Veon Bell, who did spend considerable time in the NFL, was running down the field in practice prior to the game with a perfect spiral thrown by a gentleman by the name of Kirk Cousins, who's still in the league, I believe, with Atlanta at this time. And I looked at the ball, and in the very tight spiral, Steve, how beautiful the trajectory and aspect of the ball was. And I was just watching the ball, and then Le'Veon Bell was chasing it, came right up to me and did a pirouette so he wouldn't run me over and crush my chest. That's just how athletic he was. He just brushed by my chin, and I realized that could have been calamitous, but he was just that gifted as an athlete. So in terms of how it is or what it's like on the field, it's very difficult to describe. It is an amped up, controlled chaos in a collision sport played by violent men who are highly disciplined. And I guess that's the only way I can get across what it's really like down there.
When you're on the sidelines, are you the neurologist for both teams, or do the away teams bring their own neurologists, their own doctors?
So in the Big Ten, back during what I call the decade of concussion, there were three teams that traveled with the neurologist. There was a fourth team, actually the University of Indiana, that traveled with the neurosurgeon. So teams did not travel with the neurologist back there. I belonged to Michigan State University's sideline. On 4 occasions, I was asked to help a student athlete on the opposite side.
I want to talk about concussions a little bit. You cover it in your book. And it's a huge topic in all sports, even in youth sports. For my sons, who were both high school volleyball players, every year before practice start, they had to complete a concussion training session. When it comes to concussions, would you mind explaining to the listeners what a concussion actually is physiologically, anatomically?
Of course. I like to keep that definition simple. A concussion is a force delivered to the central nervous system that alters its physiology. And the reason why I keep it simple is so that people can understand you can get a concussion not only from a blow to the head, but even from the neck or the shoulders that's transmitted up to the brain and alters the way the cells and the various systems within the brain interact with each other. You've got to be suspicious if someone's had a concussion after a significant blow to the chest, neck, shoulders, of course, to the head. And you got to be alerted to that. The fact that your sons, your children are taught about concussion is laudable. I applaud that. I think it's terrific because you have to identify it not only in yourself that, gee, I'm not right. I'm wondering if this is a concussion. You got to identify this in others around you, your teammates, to keep them safe. The reason why I say that is that a concussion usually goes away over time, but there's a thing called second impact syndrome that is quite dangerous, and I'd like to dwell on that for just a few minutes, Steve. Second impact syndrome is where you have a second concussion soon after the first, and that is quite dangerous. That is a situation where individuals can suffer brain swelling, accelerated brain swelling, and can be quite dangerous and potentially lethal. So identifying the first concussion and then disqualifying an individual from further competition, whether or not it's a contact sport or a collision sport, is essential to avoid second impact syndrome. Second impact syndrome can cause prolonged recovery in individuals. It can lead to post-concussion syndrome where the concussion doesn't clear for days or weeks. It can also cause that accelerated brain swelling from what I've just mentioned.
So what does it take to diagnose a concussion? What would be your confirming diagnosis criteria on the field?
Phenomenal question, very important. There's a thing called a SCAT-6, Sports Concussion Analysis Tool. And so the SCAT-6 is the latest version of what testing to put a student athlete or a bystander through if they've suffered a blow where a concussion is suspicious. Anybody can get on the web and look up SCAT-6, and it will produce for you the various things that you would have to go through to be cleared from a concussion. Memory, balance, things along that line, the ability to name things and so forth. So the SCAT-6 is a popular way for coaches, athletic trainers, team physicians to make the diagnosis of concussion. The typical symptoms are cognitive disturbances like memory, the ability to repeat things, headache, vision changes, double vision, the statement dizzy, mood changes, and then as you get deeper into the process, altered levels of consciousness if it gets significant. A better way to do it is a neurologic exam. Neurologists are trained to do a variety of different tests that are a little more sophisticated than a SCAT-6, looking at the vestibulo-ocular motor system, eye movements, control of ocular motility, issues related to visual fields, whether or not someone has double vision. But by and large, anybody, any civilian, any soccer mom, any volleyball dad can learn how to look for these abnormalities using the SCAT-6, S-C-A-T, SCAT-6.
Okay, that's good to know. That is good to know. I often tell my students when we talk about cranial nerves and neurology and things like that in my class, and I'll do a lab on cranial nerve testing and cerebellar function tests, and I tell my students if you have a head injury and You go to the emergency room and it looks like they're giving you a roadside sobriety test. Don't be offended. They don't think you're drunk. That is a cerebellar function test. There are cranial nerve tests involved in that as well. And it sounds like a lot of those, the vestibular response you were talking about, the eye movements, cranial nerves, 3, 4, 6, things like that, all the stuff that a lot of A&P students are learning how to do.
Well said, Steve. Thank you for highlighting that.
So in the news and in sports in general, over the last 10, 15 years, we've heard a lot about chronic traumatic encephalopathy, or CTE, especially athletes in American football. And we've had some tragedies in some former NFL players in terms of self-harm and things like that. So do we even know what role concussions play in long-term effects like CTE? And how many concussions before a player should really consider hanging it up?
Well, that's a great question, Steve, and a very important one at a variety of different levels. There is no doubt that chronic traumatic encephalopathy exists. It is real. It's been around since 1928. Maitland, in 1928, looked at boxers and realized that boxers had changes in their anatomy that clinically, when they were evaluated prior to their death, had a term called punch drunk. They had cognitive disturbances and balance issues and a variety of different mood swings and sleep disorders. And so Maitland coined the term punch drunk, or dementia pugilistica, meaning that you were a boxer, a pugilist that had altered ability to think and what have you. So that came out in 1928 and was well known to men and women such as yourself that understood neuroanatomy and neurologists and so forth. What happened, though, was years later, Mike Webster, who was a center for the Pittsburgh Steelers, who played at Wisconsin, University of Wisconsin, also known as Iron Mike, played a distinguished career for the Pittsburgh Steelers over a period of time. But after his career was over, it was understood that he had tremendous memory disorders and other cognitive disturbances. And he also had a sort of a bit of violence about him and what have you. And so he died, and the pathologist who examined him understood these sort of abnormalities that he was suffering from, Dr. Umalu. And Dr. Umalu, using his own money, after he performed the autopsy, like anyone that's brought in to the medical examiner, realized that there were multiple changes in Mike Webster's brain that were quite reminiscent of this original description in 1928. The startling thing, however, was Mike Webster played a helmeted sport. Boxers have no helmets. And so what was stunning was this dementia pugilistica in an athlete that was wearing a helmet. And that was startling. That meant that the helmet in this particular athlete was not of value to preventing this disorder. He coined a new term called chronic traumatic encephalopathy, different from the original description, but perhaps more illustrative. Chronic traumatic, blows to the head. Encephalopathy would mean a problem with the brain. So chronic traumatic encephalopathy, brain problems related to chronic hits over and over again. People believe that a more logical explanation for the development of CTE is repetitive subconcussive blows to the brain. So you don't have to suffer a concussion, but just the force being imparted to the brain over and over and over and over and over again is a more logical explanation than one or two concussions. So although concussion can lead to chronic traumatic encephalopathy, the thought is it's the chronic blows that don't knock somebody out or cause them to suffer a concussion. It's the subconcussive blows over a period of time. The amount of blows it takes to cause CTE is really the question of this age. Can we figure out the number of hits involved before somebody is retired? A sporting example, Steve, would be a pitcher. When pitchers come up to the major leagues, they're usually watched quite carefully so that they only throw a certain amount of pitches before they're removed. In the old days, you would throw 130, 140 pitches. Nobody watched you. But today with the athletes and all that's involved, the pitch count is watched very carefully. Blows to the head maybe should be very similar, where we catalog how many blows student athletes get and then professional athletes get. Certainly doing cognitive assessments serially, making sure that someone does not demonstrate any cognitive change or balance changes is also sort of essential to trying to safeguard athletes' health, particularly in our collision sports. So in shorter response, how many concussions is too many? I think the larger question is, how many hits are too many? How many physiologic changes are too many? Is there some other biomarker that could let us know when someone has had too many hits prior to there being any clinical signs that they've suffered too many plays in a collision sport? That biomarker really is the holy grail, in my opinion. Finding what that biomarker is before there's clinical change would really be very helpful.
Bombas makes the most comfortable socks, underwear, and T-shirts.
Warning, Bombas are so absurdly comfortable you may throw out all your other clothes.
Sorry, do we legally have to say that?
No, this is just how I talk, and I really love my Bombas.
They do feel that good. And they do good, too. One item purchased equals one item donated.
To feel good and do good, go to bombas.com and use code AUDIO for 20% off your first purchase. That's BOMBAS.com and use code AUDIO at checkout.
I know you've done some research on concussions. Is this part of the focus of some of your research?
It is. So when I was invited to be part of the team in 2010, it struck me there were no biomarkers. Can we come up with a biomarker that would allow us to know in an expedited way, did somebody have a concussion, or was there some aspect of the physiology that we should watch for? So in consortial relationship with the Department of Intercollegiate Athletics, the Department of Neurology, and the Department of Radiology here at Michigan State University, we designed a test using a thing called functional MRI scan. Functional MRI uses blood flow to determine brain activity and the connectivity of various systems within the brain. We were able to do a functional MRI within 24 hours of someone suffering a concussion, repeat it at 1 week, and then repeat it at 4 weeks to see if there was any change. And so 70 members of the football team signed up. We did all 70 preseason. Then 11 individuals had a concussion that were in a situation where we can do a functional MRI within 24 hours. And then we did another functional MRI 1 week and 4 weeks. What we found was at the acute onset, the functional MRI showed hyper-excitability. It showed hyper-connectivity of the various systems of the brain. That at 1 week, the exams were normal in all 11 of these individuals, but the functional MRI showed reduced connectivity, hypoconnectivity at 1 week, even though their exam had converted to normal. And at the end of a month, the exams, of course, remained normal, but people approached but did not quite get back up to the baseline of a normal functional MRI scan. We found this to be a potential biomarker in individuals. This was published in the Journal of Neurotrauma, I think around 2014 or 2015, and you could look up that paper in the Journal of Neurotrauma. But I still believe the most logical way to do it is the clinical examination. It's the fastest and I believe a highly reliable way to make that diagnosis.
A couple of things about that struck me. One is that over the course of one season, 15% of the players that you signed up suffered a concussion. That seems like a very high incidence of concussion. It's like you said, it's a collision sport. I mean, 15% seems like a lot. But then the other thing I'm thinking is, should we be using the functional MRI to determine when athletes can return versus just a neurological exam?
So I think that's a very important question, Steve. The clinical relevance of that finding is unclear. We do not know whether or not this has a relevant understanding of long-term outcome or safety. That is work that needs to be done. Like any clinical decision, the technology needs to be an extension of the clinical exam. And a logical, responsible physician doing a clinical exam and then validating their conclusions with technology is, I think, the best way to proceed with any clinical situation. I do believe that you should have balance testing and a thing called impact testing. Impact testing is computerized neuropsych testing using a variety of different brain systems. Balance testing using a best test. And of course, it is my strongest bias that a careful examination by a neurologist or someone skilled and trained and understand and can perform a proper examination in at the SCAT-6 or higher level, I think is the best way to make that decision.
I imagine that the players and the coaches might fight having to wait for that functional MRI also, because that might take a little while. So outside of concussions, if you don't mind me asking, what is the worst injury you've seen on the field?
So there have been several memorable ones. A gentleman by the name of Josh Rouse dove over a pile. This is my first game. Dove over a pile to try to make a tackle on a punt. He hit the ground head first, and I watched him get up and walk slowly off the field. But because of the swirl of action, I didn't truly realize that he was injured. And when something like that happens, you're supposed to meet at the training table, which is set up on the sidelines. Back then, we didn't have a tent. And because of the swirl of action and all these things happening and the chaos and my lack of understanding it as a first game neurologist, I did not go there to the training area. About 10 minutes later, the lead athletic trainer, Jeff Monroe, comes over and says, "We need you in the locker room." I said, "Well, what's up?" And he explained that Josh Rouse seemed injured on that play and maybe he had a concussion. They weren't sure. And so I went with him to the locker room, and what I saw was a young man coming out of a shower, of all things, and tremendous trapezius muscle, the muscle, of course, that allows you to stabilize your head. And he was walking a very stiff way with his shoulders up near his ears, very hesitant to turn his head. He wouldn't turn his head. He would only look with his eyes from side to side, would not move his head. And what was interesting was they had taken x-rays of him, and I noticed the x-rays showed a fracture of his dens, which is a bone in the, as you know, in the second vertebrae that allows the head to pivot and turn. And I was surprised that it was his x-rays, but I understood that he had a fracture dislocation of his dens, what is also known as a hangman's fracture variant. My first game, and I realized here was an event that could be life-ending or cause a quadriparesis, a paralysis of all four extremities. But fortunately, there were phenomenal orthopedic surgeons, and Jeff Monroe was there, and we put a Miami J collar around his neck, stabilized him, got him boarded up, and we were able to successfully send him to the emergency room, where neurosurgery the following day was able to secure his dens and stabilize him and save his life. So that was my first game, and I learned pretty quickly this is a collision sport. It is, and it's there's danger.
That was a close call for that player. My listeners may know that DENS is also known as the odontoid process. Sometimes you'll hear it called that as well. And then the potential risk to the cervical spinal cord is so precarious. As a fan, I'm going to ask this. Besides the Notre Dame game, were you on the sideline for any other historic games at Michigan State?
Well, yes. From 2013 to 2015, MSU lost 5 games. In 2013, MSU played Ohio State in the Big Ten Championship. The winner, if it was Ohio State, would go on to play for the mythical national championship back then. Ohio State had won 24 straight football games, 24 football games in a row. And Michigan State was fortunate enough to win that game by 10 points. That was pretty historic. Michigan State then played the Stanford Cardinal in the Rose Bowl in a tremendous game, leading Stanford by 4 points with less than 3 minutes, with Stanford having the football on 4th and 1. What I watched were two lines of human beings, each weighing somewhere between 270 and 330 pounds, collide. As a neurologist, I winced. It was a horrible thing to watch, but also breathtaking simultaneously. Michigan State collapsed the Stanford line. Kyler Ellsworth was credited with diving over the Stanford line and tackling the fullback behind the line of scrimmage to give the Rose Bowl victory to MSU. So there was that game, which is memorable.
So I don't want to take too much more of your time. You've been super generous with your time. However, in the NCAA and in the NFL, every year we see rule changes to help make players safer. And I would hope that people like you are consulted on some of these decisions. If you were consulted, what recommendations do you have to make American football safer for the players?
It's the repetitive blows that are the issue, Steve. But the high velocity hits are what cause concussion. The most dangerous plays are kickoffs and punts. The kickoff rules have been changed, as people have noticed, both in the Big Ten, or in college football rather, and in professional football. What most people don't understand is the high number of concussions occur in practice. One of the other major changes was during practice that you could not have the number of hitting practices as in the old days. It was called toughening up the players, but it caused so many injuries, it was just ridiculous. So hitting practices were reduced and then monitored carefully at the professional level and also at the collegiate level. That was huge. I think that was a very important change. And then there are the Guardian helmets that came on during practice, these soft helmets over the hard shells. What people realized is the best way to disperse force isn't making harder helmets. You want to make softer helmets. And so these Guardian helmets that fit over the helmet has also helped, and the numbers have reduced over time. So alter the high velocity hits, reduce the hitting practices, the Guardian helmets. Really what it comes down to, Steve, and people may or may not understand that, until people respect their opponents as much as they respect their teammates and themselves, we will never get to a point of truly effective safety. Players have to respect their opponents' safety as much as they respect their own safety in those players. And that's a long way to go. That's counterintuitive to winning. Now, there is a sport called Ultimate, and it's about Frisbee. The reason why I admire Ultimate is it strikes me that those players have as much concern about the care of the other team as they do their own. Until we reach that stage, it will always be a very, very dangerous sport.
Well, I do like hearing that. You don't want anyone getting hurt, even if it's the other side, because, everyone who's playing is doing this as a student athlete or for a profession. They've got careers, they've got families and all that stuff. And that does sound good. And I've seen some guys in the NFL wearing the Guardian helmets, even in games, which I think is pretty good to see. So like I said, you've been enormously generous with your time. I really enjoyed getting to hear your story. Thank you so much, Dr. Kaufman, for coming on, and good luck with the book. I read on your website that the proceeds are going to a couple of different charities. So that's really nice to hear. I will put the link to your website, which is davidikaufman.com, in the show notes so people could take a look at that. Do you want to mention those charities real quick?
For the Webster Fund, which is to assist people with having an opportunity to come back to Michigan State University to graduate. Once their scholarship time has been ended, it allows them to come back on campus and take courses to get their degree. The other one was my roommate on the road during these football trips, Father Jake Folio, The Jake Folio Chair of Spirituality is the other charity to honor the team chaplain for those football teams that I was a part of. Tremendous individual. Thanks, Steve.
Well, that's really, really nice to hear. I hope everybody gets the book. I'm looking forward to finishing it. I've got a vacation coming up, and I definitely got something to bring on the plane now. So thank you so much, Dr. Kaufman. It was a pleasure.
Thank you, Steve.
Okay, that was a fun conversation. I love hearing about the clinical aspect of sports, especially at the elite level like Michigan State University. I hope you enjoyed that. Once again, Dr. Kaufman's book is called We Need You in the Locker Room, a neurologist's journey behind the scenes of major college football. You can find it at davidikaufman.com. I put links in the show notes to Dr. Kaufman's website, both causes that his book supports, and his concussion research. Concussions are serious neurological conditions, and if you're aspiring to be a clinician of almost any sort, you will absolutely come across patients with
Bombas makes the most comfortable socks, underwear, and T-shirts.
Warning, Bombas are so absurdly comfortable you may throw out all your other clothes.
Sorry, do we legally have to say that?
No, this is just how I talk, and I really love my Bombas.
They do feel that good. And they do good, too. One item purchased equals one item donated.
To feel good and do good, go to bombas.com and use code AUDIO for 20% off your first purchase. That's BOMBAS.com and use code AUDIO at checkout.
This is the story of the one. As a maintenance supervisor at a manufacturing facility, he knows keeping the line up and running is a top priority. That's why he chooses Grainger. Because when a drive belt gets damaged, Grainger makes it easy to find the exact specs for the replacement product he needs. And next-day delivery helps ensure he'll have everything in place and running like clockwork. Call 1-800-GRAINGER, click Grainger.com, or just stop by. Grainger, for the ones who get it done.
concussion. We ended the last episode just before getting to serum lipids, which is the way lipids are transported in our bloodstream. So let's pick it up there. Recall from the endocrine episodes that hydrophobic substances like lipids struggle to travel through the watery blood plasma. The challenge is that we have to digest and absorb lipids via our gastrointestinal tract so they can make it to all of our cells. When it came to lipid-soluble hormones, we used transport proteins, which bound the hormone and created a water-soluble complex that we could transport much more easily. As luck would have it, dietary lipids work in a similar way, which we call lipoproteins. Lipoproteins are tiny droplets with a cholesterol and triglyceride core coated with phospholipids and apolipoprotein. Lipoproteins remain suspended in the blood thanks to those phospholipids. Apolipoproteins contribute to the formation of lipoproteins and stabilize them. They're also identifying markers so that cells that need their lipids can tell what they are. You'll usually hear these referred to as serum lipoproteins. Blood serum is blood plasma without the clotting proteins. Although there are several categories of lipoproteins, there are 4 clinically significant ones we're going to focus on. They're classified by their density. They are chylomicrons, high-density lipoproteins, or HDLs, low-density lipoproteins, or LDLs, and very low-density lipoproteins, or VLDLs. Lipid is less dense than protein, so the higher the proportion of lipid to protein, the lower the density. You've probably heard of HDL, LDL, and VLDL. These are categories we see when we are talking clinically about blood cholesterol. The quote-unquote cholesterol in our blood is not just pure cholesterol molecules. They are in the form of lipoproteins. The lower density lipoproteins, LDL and VLDL, have more lipid and are more dangerous as they contribute to the plaque formation in our arteries that causes coronary artery disease. That's why we call these bad cholesterol. While the HDL, the high-density lipoprotein, is called good cholesterol because it actually helps remove the low-density lipoproteins from the blood. Their most important differences, however, are in the composition and function. There are 3 primary pathways by which blood lipoproteins are made and processed. So let's walk through the journey of lipids in the body, focusing particularly on how the body packages, transports, stores, and disposes of fats and cholesterol. These mechanisms are not only central to human metabolism, but also vital in understanding cardiovascular health and the rationale behind various dietary and lifestyle recommendations around cholesterol and lipids. We'll begin in the small intestine, where dietary fats are absorbed. Inside the absorptive epithelial cells, which we call the enterocytes of the intestinal lining, dietary lipids are packaged into large lipoprotein particles called chylomicrons. You heard about those in the digestive episodes. These are essentially transport vesicles designed to carry triglycerides, cholesterol, and fat-soluble vitamins through the aqueous environment of the body. Because chylomicrons are too large to enter blood capillaries directly, they first enter the lymphatic system via lacteals and then eventually drain into the bloodstream later on. Once in the bloodstream, chylomicrons encounter an important enzyme, lipoprotein lipase, which is located on the endothelial surface of the capillaries, particularly those in adipose tissue and muscle. Lipoprotein lipase hydrolyzes the triglycerides in chylomicrons into free fatty acids and monoglycerides, which can then diffuse across the capillary wall. In adipose tissue, these fatty acids are taken up by adipocytes and reassembled into triglycerides for long-term energy storage. However, not all fatty acids are taken up immediately. Some remain in the plasma, bound to albumin as a transport mechanism. Once chylomicrons have delivered their triglyceride cargo, what remains is a smaller particle called a chylomicron remnant. These remnants are taken up by the liver, where they are broken down and recycled. Now let's turn to the liver's role in lipid transport. The liver produces its own class of lipoproteins. Those are the very low-density lipoproteins, or VLDLs. These are similar in function to chylomicrons, but serve a different purpose, transporting triglycerides synthesized endogenously from glucose or other sources to adipose tissue for storage. As VLDLs offload their triglycerides in peripheral tissues, they shrink in size and density, transforming into low-density lipoproteins, LDLs. LDLs are rich in cholesterol, and this is where their role becomes more clinically relevant. Cells that require cholesterol for membrane synthesis or for producing steroid hormones express LDL receptors on their surface. Through receptor-mediated endocytosis, they internalize the LDL particles, digest them in lysosomes, and release the cholesterol for intracellular use. That is a tightly regulated process, but when overwhelmed or dysfunctional, it can contribute to atherosclerosis, which is the plaque formation in your arteries. Now let's contrast this with high-density lipoproteins, or HDLs, which function as the body's cholesterol scavengers. The liver produces HDL particles as empty or partially empty protein shells. These circulate through the blood, picking up excess cholesterol and phospholipids from peripheral tissues and other lipoproteins. When HDLs pass back through the liver, the cholesterol they carry is removed and either repackaged into bile acids or secreted directly into the bile. Thus, HDL plays a key role in reverse cholesterol transport, one of the few mechanisms that the body has for eliminating cholesterol. So now we come to a critical clinical question. What do these lipoproteins mean in terms of blood cholesterol levels? The general target is a total plasma cholesterol level of about 200 milligrams per deciliter or less. Levels between 200 and 239 are considered borderline high, and levels above 240 are clearly associated with increased cardiovascular risk. However, these numbers alone don't tell the whole story. It's not just how much cholesterol you have, but how it's distributed among the different lipoproteins. Once again, it's important to understand and to explain clearly to patients most of the cholesterol in your body isn't coming from your diet. It's made by your liver. The body has a feedback system to maintain homeostasis. When dietary cholesterol intake increases, the liver reduces its own production and vice versa. This is why for many people, reducing dietary cholesterol has minimal effect on their serum cholesterol levels. In fact, current research shows no strong correlation between dietary cholesterol and blood cholesterol levels. That's why public health guidelines have recently moved away from restricting cholesterol intake per se. Instead, attention has shifted to saturated fatty acids. Certain saturated fatty acids, particularly palmitic acid, raise serum cholesterol, not by adding more cholesterol to the diet, but by blocking the uptake of cholesterol by tissues, leaving more circulating in the blood. Interestingly, not all saturated fats behave the same way. Stearic acid, which has 2 additional carbon atoms compared to palmitic acid, does not appear to raise cholesterol levels. This biochemical nuance is often lost in food marketing. A product might be labeled cholesterol-free but still be high in saturated fats that can increase LDL cholesterol and cardiovascular risk. So reducing intake of saturated fats can lower serum cholesterol levels by 15 to 20%, which is considerably more effective than reducing cholesterol intake directly. On the other hand, unsaturated fatty acids like linoleic acid can help lower cholesterol levels and are considered cardioprotective. So now let's look at the role of exercise in lipid metabolism. The mechanism is somewhat indirect but quite powerful. Vigorous aerobic activity reduces the sensitivity of the right atrium to blood pressure. This results in decreased secretion of atrial natriuretic peptide, which in turn reduces sodium and water excretion by the kidneys, increasing blood volume. This dilution of plasma lipoprotein stimulates adipocytes to increase production of lipoprotein lipase, which enhances triglyceride clearance from the blood. As VLDLs shrink, they release cholesterol, which is picked up by the HDLs and returned to the liver. So exercise doesn't just lower triglycerides, it enhances HDL activity and promotes cholesterol clearance. So let's tie this back to the clinical interpretation. A high LDL level is concerning because it reflects a high rate of cholesterol deposition in arterial walls, a key factor in atherosclerosis, which is, in the coronary arteries, the number 1 cause of death in the world. This is why LDL is often referred to in the media as that bad cholesterol I mentioned earlier. While that phrase is technically misleading because LDL particles contain more than just cholesterol, it gets the point across. Excessive LDL is a risk factor. LDL levels are elevated by saturated fat intake, cigarette smoking, and stress. On the flip side, HDL is labeled good cholesterol because of its role in cholesterol removal. A high HDL to LDL ratio is considered protective and desirable. The best way to improve this ratio is a combination of diet low in calories and saturated fat and regular aerobic exercise. So let's summarize up the lipids. The transport and metabolism of lipids involve a complex interplay of chylomicrons, VLDLs, LDLs, and HDLs, each with its own role in energy storage, cellular structure, and cholesterol regulation. As clinicians and scientists, understanding these mechanisms allows us to interpret lipid panels more effectively, educate patients with evidence-based recommendations, and implement interventions that address the underlying physiology, not just the numbers. Okay, now let's take a closer look at proteins, macromolecules with perhaps the widest range of functions in the human body. Proteins make up approximately 12 to 15% of your total body mass, and about 2/3 of that is found in skeletal muscle. But their significance extends far beyond muscle tissue. Functionally, proteins are indispensable to nearly every biological system. They're the molecular engines behind muscle contraction and the motility of cilia and flagella, which are essential for the movement of fluids across epithelial surfaces and for the mobility of sperm cells. And on the structural side, proteins are the building blocks of all cellular membranes, where they act as receptors, transporters, ion channels, identity markers, you name it. In connective tissues and the integumentary system, fibrous proteins like collagen, elastin, and keratin form the backbone of bones, cartilage, tendons, ligaments, skin, hair, and nails. In contrast, globular proteins have more dynamic functions. These include enzymes, antibodies, hormones, neuromodulators, and oxygen-binding proteins such as hemoglobin and myoglobin. Enzymes alone number in the thousands and control nearly every aspect of cellular metabolism. Plasma proteins, including albumin, help regulate blood viscosity, osmolarity, and act as transporters for lipids and other solutes. Proteins also play critical roles in pH buffering and contribute to the resting membrane potential of cells. In short, there is no other class of biomolecule with such a diverse portfolio of roles in human physiology. So now, let's talk about the protein requirements. For a healthy adult, the recommended dietary allowance for protein ranges from 46 to 56 grams per day, depending on sex and age. A quick calculation can be done by multiplying body weight in pounds by 0.37, or in kilograms by 0.8. That will estimate an individual's daily protein needs in grams. However, this requirement increases under several conditions such as intense physical activity, trauma, infection, surgery, or pregnancy, due to higher rates of tissue turnover or synthesis in those situations. Infants and children also require proportionally more protein relative to body weight due to their rapid growth spurts. It's important to note that excessive protein intake, as seen in some high-protein diet fads, can stress the kidneys due to the increased load of nitrogenous waste from amino acid catabolism, potentially leading to renal damage over time. So let's talk about amino acids and protein quality. Protein quality is not just about the total quantity, but also the amino acid profile. The human body requires 20 amino acids, but only 8 are essential in the adult diet because they cannot be synthesized by the body. So the essential amino acids, the one we cannot synthesize, are isoleucine, leucine, lysine, methionine, phenylalanine, threonine, tryptophan, and valine. For infants, histidine is also considered essential. 2 other amino acids, cysteine and tyrosine, can only be synthesized from essential precursors, methionine and phenylalanine. So they're not really essential, but we need the essential amino acids to make them. So here's the critical point. For the body to synthesize a specific protein, all required amino acids must be available at the same time. Even if one is missing, just one, protein synthesis halts. This is why we distinguish between complete proteins, which contain all essential amino acids in proper proportions. We typically find these in animal products. And incomplete proteins, which lack one or more essential amino acids, which we often find in plant products. For example, grains tend to be low in lysine, and legumes are low in methionine. But if we consume them together, like in a plate of rice and beans, they complement each other and form a complete amino acid profile. Another factor to proteins is how much of the ingested protein the body can actually use. This is known as net protein utilization, or NPU. We utilize 70 to 90% of amino acids in animal proteins, but only 40 to 70% in plant sources. This means you'd need to eat significantly more plant protein to get the same usable protein as a smaller amount of animal protein. For instance, 400 grams of rice and beans to match the protein utility of 115 grams of lean meat. That said, shifting toward plant-based proteins has several health and environmental advantages. Plant-based foods provide more fiber, vitamins, and minerals, and they contain less saturated fat, cholesterol, and chemical contaminants. They also require significantly less land and resources to produce, an increasingly relevant factor given the global food demands and environmental sustainability. So let's talk about the dietary sources of proteins. Animal proteins, like those from meat, eggs, and dairy, closely mirror human protein in amino acid composition, making them high-quality sources. But even without animal products, it's entirely possible to achieve adequate protein nutrition by strategically combining plant sources, a common practice in regions where meat is scarce or very expensive. About 2/3 of the global population subsist on diets with little to no meat and still meet their protein needs. All right, so now let's shift to the concept of nitrogen balance, a key measure of protein metabolism. Proteins are the body's primary source of nitrogen, and nitrogen balance reflects whether intake and excretion are equal. A positive nitrogen balance means intake exceeds excretion. This often occurs during growth, pregnancy, and resistance training, when the body is building new tissue. A negative nitrogen balance occurs when excretion exceeds intake, typically during illness, starvation, or inadequate caloric intake. In this state, the body catabolizes its own protein stores, especially from muscle and liver. And that is how we meet our energy demands, leading to muscle wasting and atrophy. An important point here is the protein sparing effect. This is the effect that carbohydrates and fats can have. When sufficient calories from carbs and fats are available, the body will use them for energy and spare the proteins for their intended roles in tissue maintenance and enzyme function. But when these energy sources are lacking, protein is diverted and broken down for fuel, increasing the risk of negative nitrogen balance.
Bombas makes the most comfortable socks, underwear, and T-shirts.
Warning, Bombas are so absurdly comfortable you may throw out all your other clothes.
Sorry, do we legally have to say that?
No, this is just how I talk, and I really love my Bombas.
They do feel that good. And they do good, too. One item purchased equals one item donated.
To feel good and do good, go to bombas.com and use code AUDIO for 20% off your first purchase. That's BOMBAS.com and use code AUDIO at checkout.
Finally, the endocrine system has a profound impact on protein metabolism. Growth hormone and steroid hormones like estrogen and testosterone promote protein synthesis and help maintain positive nitrogen balance during development and reproduction. On the other hand, glucocorticoids, such as cortisol, promote protein breakdown and are associated with negative nitrogen balance, especially during times of stress, illness, or extended fasting. So basically, the proteins are essential not only for structure and function, but also for metabolic homeostasis. Understanding amino acid requirements, protein quality, nitrogen balance, and the impact of hormones and diet on protein metabolism is key to nutritional biochemistry and clinical medicine alike. Whether you're treating a malnourished patient, counseling someone on plant-based diet, or managing a critically ill patient in a catabolic state, these principles will guide your decision-making. All right, let's take some time to talk about two groups of nutrients that are essential for life, but often overlooked because nutrition and dietary discussions tend to be focused on macronutrients. These are the micronutrients, minerals and vitamins. Although they don't supply energy and aren't burned off as fuel, they're absolutely vital for the metabolism and utilization of other nutrients. Without them, many of the body's essential biochemical processes would grind to a screeching halt. So both minerals and vitamins are classified as micronutrients because we need them in relatively small quantities compared to proteins, carbohydrates, and fats. Despite their low required amounts, their physiological effects are powerful, and both deficiencies and excesses can lead to serious, sometimes life-threatening conditions. Many of those substances cannot be synthesized by the human body, or are only synthesized in small amounts, which means they must come from the diet. We'll start with minerals. These are inorganic chemical elements, most of which are metals that plants absorb from soil and water and that enter our bodies through the food we eat. Minerals make up about 4% of total body mass, and most of that, roughly 3/4, is tied up in bone and teeth as calcium and phosphorus. But phosphorus, for example, isn't just a structural component. It's also critical to cellular signaling and energy metabolism. It's present in phospholipids, nucleic acids, ATP, cyclic AMP, GTP, and creatine phosphate. You heard of all of these in previous episodes. It's also the cornerstone of the phosphate buffer system, which helps regulate pH in the body. Several other minerals serve as enzyme cofactors. For example, calcium, magnesium, iron, and manganese assist in a variety of enzymatic reactions. Iron is also crucial for oxygen transport in both hemoglobin and myoglobin. Chlorine, in the form of chloride, which is the ionic form, contributes to gastric acid production in the stomach. Hydrochloric acid. Again, in a previous episode, we talked all about the synthesis of hydrochloric acid. Minerals also play a central role in electrolyte balance, nerve and muscle function, and osmoregulation. You're familiar with sodium, potassium, calcium, and chloride ions, and you know how their electrical signaling, how they affect blood volume, fluid distribution across compartments. We've seen them crossing the plasma membrane for local potentials, action potentials, all that stuff. We've been talking about these ions and minerals throughout so many episodes. So now you're just kind of seeing how they're important for us to consume because that's how we're going to get them. So in terms of dietary sources, the best mineral-rich foods include vegetables, legumes like beans, milk, eggs, fish, shellfish, and meats. While cereal grains tend to be relatively poor in mineral content, they are often fortified during the processing to correct for this. What that means is that the food manufacturer adds vitamins and minerals to a food that doesn't necessarily have those vitamins and minerals to make sure the population gets them in their diet. So you'll often see things like iodized salt. Iodine is not naturally occurring in salt. But there was a period of time in the US that iodine levels were low and people were having iodine deficiencies, and it was affecting their thyroid. So what they decided to do was to fortify table salt with iodine. So that way people who use salt are getting the iodine in their diets. They put things like vitamin D in milk. Vitamin D is not naturally occurring in cow's milk. It is fortified with vitamin D because vitamin D is essential for calcium absorption. And people are using that milk to get their calcium levels, so they need the vitamin D to make sure that they can absorb it. Now, a particularly interesting case in human nutritional history is sodium chloride or salt. Unlike animal products, which naturally contain plenty of salt, plants are poor in sodium. So herbivores, and by extension agricultural humans, have historically needed a supplement salt intake. The significance of salt was so high in early economies that the word salary is derived from sal, the Latin word for salt, sal. You probably heard someone say, I don't think he's worth his salt. That's probably where that phrase came from. The modern controversy around salt intake and hypertension is something you've probably heard of. The human kidney is remarkably efficient at excreting excess sodium, and many studies have failed to show a clear link between high salt intake and hypertension in healthy individuals. However, in susceptible populations, such as people with renal disease, diabetes, or genetic salt sensitivity, salt could exacerbate hypertension or high blood pressure. To provide some guidance, the National Academy of Medicine recommends a daily sodium intake of 1.5 grams, which is 1,500 milligrams, with an upper limit of about 2,300 milligrams. In contrast, the average American consumes about 3,400 milligrams per day, largely from processed and restaurant foods, which account for roughly 77% of our sodium intake. All right, let's finish up with vitamins. Vitamins are organic molecules required in small amounts to support normal metabolism. They don't provide energy, they don't build tissues, but they do facilitate essential metabolic reactions, often by acting as coenzymes or cofactors. Many of the vitamins are assigned letter names based on their order of discovery, like vitamins A, B, C, D, E, and K. But they also have chemical names. For instance, vitamin C is ascorbic acid. Vitamin A is retinol. Vitamin D is cholecalciferol. Vitamin E is also known as tocopherol, among other names. Vitamin B is a complex of 8 different vitamins. Vitamin B1 is thiamine. Vitamin B2 is riboflavin. B3 is niacin. B5 is pantothenic acid. B6 is pyridoxine. B7 is biotin. B9 is folate. And B12 is cobalamin. The reason why there's no B4, 8, 10, or 11 is that compounds thought to be B vitamins long ago were given these names, but have since proven not to be vitamins after all. So they pulled them out. While most vitamins must be obtained from the diet, some can be synthesized in small quantities from provitamins, vitamin precursors. For example, niacin, which is vitamin B3, can be made from tryptophan. Vitamin D is synthesized from cholesterol with ultraviolet light exposure. Vitamin A can be derived from carotene, found in yellow and orange vegetables. In addition, the gut microbiome in the large intestine synthesizes several vitamins, including vitamin K, biotin, pantothenic acid, and folic acid. Interestingly, feces often contain more biotin than most foods do. This is because of microbial activity. So vitamins fall into 2 categories, water-soluble and lipid-soluble. Vitamin C and the B-complex vitamins are the water-soluble vitamins. They dissolve in water, they're absorbed easily in the small intestine, and they circulate freely in the body fluids. Because they are not stored in significant amounts and are readily excreted in the urine, toxicity is rare, but also so is long-term retention, so you need them all the time. Vitamin C, or ascorbic acid, supports collagen synthesis, wound healing, hemoglobin production, and acts as an antioxidant, which means it neutralizes free radicals. B vitamins act as coenzymes in energy metabolism, facilitating redox reactions and enzyme function in carbohydrate, lipid, and protein metabolism. The lipid or fat-soluble vitamins are A, D, E, and K. They are absorbed with dietary fats, stored in the liver and adipose tissue, and are more prone to accumulate to toxic levels. Vitamin A supports vision, epithelial health, and immune function. Vitamin D is critical for calcium absorption, like I mentioned earlier, and bone mineralization. Vitamin E acts as an antioxidant, and vitamin K is essential for clotting factor synthesis, especially prothrombin. Well, that covers macronutrients and micronutrients in terms of what they do for our bodies and what we need them for. But we still have one more thing I want to cover in nutrition before we finish it up, and that is what happens when our vitamins and minerals are deficient and what happens when we have too many of them. So I want to talk about vitamin and mineral deficiency and vitamin and mineral toxicity in the next episode. Once again, thank you so much to Dr. David Kaufman, neurologist from Michigan State University. I really appreciate him sharing his experiences with us. You can read all about his experience as the sideline neurologist for big-time football powerhouse Michigan State University in his book, which is titled We Need You in the Locker Room, a neurologist's journey behind the scenes of major college football. You can get that book on Amazon, or you can check out the link in my show notes, and that will show you how you can get that book as well. I highly recommend it. Very exciting read, especially for anyone interested in a clinical field. And of course, thank you for listening. I really appreciate it. I couldn't do this without you. I hope this is helping you get your B or better in A&P. Good luck, and I'll talk to you next time. Anatomy and Physiology Bit by Bit is a production of Minus 55 Media. Don't forget to check out my Instagram account and my YouTube channel, both called Student Help for AP. I'm posting a lot of stuff on there right now that you can watch and that will hopefully really help you understand this A&P stuff. Very special thank you out to my family, Bucks County Community College, and McGraw-Hill Education, where you can find my tutor video-based textbook alternative Anatomy and Physiology digital suite, already being used by several colleges and universities throughout the United States.